To everybody, and thank you for being back to the hybrid live course. The title of this session is Stop and Go, all you wanted to know about the imaging, and I might say the physiology guidance. Is done in 2 days, the program. This is the second day, focus on complex disease, and having at the center the Department of Cardiology of the second affiliated hospital in Harbin. So let me share a little bit this few data with the Vice Director of the Cardiology Department, Haibo, Jian. Haibo, can you comment a little bit about what is Harbin in terms of activity?
Sure. So first, on behalf of the Director of the Professor Jibo, and so welcome all the excellent experts from Europe and APEC area. So our department was established in 1978 and now ranked top 10, the best cardiology in China out of more than 500 hospitals. So we have 8 unit area and 2 CCU, including 80 bed in CCU and over almost 600 bed, which we have 130 doctors and 264 nurses and 14 technicians. So here are some pictures of our cath lab. We now have 8 cath labs, including for coronary intervention and structural disease, and also AP. So this is overall work, what we have done in the last 5 years. So this year, in 2021, we complete over 10,000 treatment PCI cases, including over 4,000 imaging-guided PCI, including OCT and IRIS, and over 1,000 EP cases and structural disease.
Okay, Haibo, thank you very much. Let's go back to the full audience. This audience is not only online with leader facilitators and panelists that will interact with the cath lab, but we wanted to be in touch with you in 2 directions, making you some questions we already addressed to everybody through WeChat, and getting back your feedback through the pool. So this is the format we are going to use during the meeting. And very quickly, I'm going to give the ball to Jose de la Torre Hernandez. Jose is a friend, is going to talk about this young man with unstable angina and multivessel disease and diffuse disease. Jose is located in Spain, in Santander. Please, Jose.
Hello, Julio. Thank you very much. A pleasure to attend this meeting. It's really great. I had the opportunity yesterday to attend the first, and now we're going to work on the day second. We expect to have a fantastic case from Harbin. This is a patient, a 52 years old male that is presented with non-STEMI. As you can see in the slides, there was a very tight lesion in the distal right coronary artery, very severe. And in the left coronary artery, we have diffuse disease, which is totally clear. We have diffuse disease affecting the proximal lead, the distal lead main, all the proximal LAD diffuse, even the mid-distal LAD, also an occlusion of second of this marginal. And in the projection from cranial, you see clearly the LAD concentrational disease. The right coronary artery was treated with 329 drug-eluting stent. And then for today, we have the left coronary artery with the spending on treatment. We have here the scheme of what really we have for this case. We have diffuse disease in LAD, then we have to discuss to assess with imaging or with physiology. We have different alternatives. We have QFR, which doesn't need the wire. It's just based on a geography, 3D. We have FFR, resting indexes like RFR, and we have to discuss how to assess and treat. Also, it's important if we're going to perform PCI to select the landing zones and the stent sizing. what to do with the side branch protection treatment, what is optimal stent expansion, what criteria can be used. Regarding lead main, we have a distal lead main that is not definitely significant, that is intermediate and ambiguous, and we need to discuss how and when to assess and what is going to be the stent strategy once we demonstrate that is significant. And finally, we have this chronic total occlusion of the second marginal branch, and we have to figure out if we treat or not and how to evaluate this lesion. Then I go to the CAP lab in Harbin, to this fantastic team that is working there. And please, Dr. Haibo, explain to us what are you doing, what imaging, what is your strategy? Haibo?
Yeah, okay, so let's move to the cath lab.
Hello, everyone.
Yeah, Dr. We can hear you. Yeah.
Yes, everyone can hear me. Yes, this is cath lab in our department. And here is Jingbo Hou, and my assistant is Dr. Yang Guang, and technician is Professor Huai Yu. And Dr. Torre had talked about the case history of this patient. And we know that this is multi-vessel disease because last week and we finished the PCI for the RCA. And today we gave the angio to the RCA, and you can see the result of RCA is very good. And then we moved to left coronary artery. And you already know that we have the intermediate stenosis at the distal part of left mean. And you can pay attention to this patient with the diffuse stenosis along distal the circ, but that's not serious. The most serious one is about 2 side branch. One is the second OM, and you can see here is the subtotal. And then let's move to LED. You can see here the tight stenosis along proximal LED and affect 2 side branch, and the first and the second diagonal. And then go to another position, you can see that the third diagonal is subtotal occlusion. And so I think that this is a complex case because we must pay attention to so many lesions and side branch, how to do. And so I think that the second OM is very big, subtotal. And so at first, we just give a guide wire. This is CL balloon, and with the 2.0 balloon to pre-dilate it, and not very high pressure. It's only 10 ATM. And then after then, you can see this is just about the diameter is 2.0 OM. And so then we use this is a scoring balloon, 8 to 10 ATM to further pre-treat this OM. And after that, because I think that my strategy is not waste too much time to this side branch, and because it's not so big, and so I gave a drug coating balloon, 2.0 40 at length, and you can see here is the drug coating balloon. After the drug coating balloon, we have a very good result about OM, and then we must pay attention to LED and the left mean and so many bifurcation. And so get wire into the LED. And here, because I think that the very tight stenosis at the proximal bifurcation part of LED and diagonal, we must first treat this lesion. But we have 2 questions. It is normal at the root of LED or not? If the root of LED is with a big plaque burden, maybe we will 2 stent from LED and to left mean. But if the root of LED is normal, it's subnormal, and I think that maybe just a precise stent implantation. And so then I just in minutes after that, okay, in minutes and here just pre-delete LED. And I want you to decide to do the OCT, just pre-balloon, just pre-dilate LED. I just do OCT examinations because I want to know what kind of lesion, the lesion characteristics, and how about the left main and the root of LED. And so now you want to know the result OCT? Chairman?
Did you get the result of the CT, Dr. Ho?
Yes.
Or they're going to perform now?
Already
Do you have? Can you show
okay.
us? Can
Okay.
you show us, and then we can discuss what to do with the imaging? This is the OCT in LED.
Okay, you can see it's very tight stenosis, but we just with some contrast into LED, then just pass through the get very fast. And you can see from the middle to the left main, we get the OCT in high quality. And from beginning, give the OCT.
Okay.
Can you give OCT in big picture?
We have a nice registration study of OCT showing a diffuse disease, no, with the, look at there, yeah.
Professor Huai,
Wow.
you say something about OCT result?
Okay. I'll browse one time. Okay. This hole is occurring because of the severe stenosis of professional LED. But the reference have severe calcification, but the vessel is normal. The stenosis site is most of the fiber. This area is 0.8 and 8. We can see the second diagonal is here. In muscle plaque in here. The first diagonal is here. The open ostium is well here. And this is the root of LED. The lumen area is 6.27. Much more better. We can see some sunburst, white sunburst here, but it's very little here. Okay.
Left me.
Left mean. It's the distal left mean. The area is 4.44 millimeter square. Okay.
So, panelists, you now know the OCT result.
Yes.
Okay, and you can give some comments.
Yes. I would like to have my colleagues, Dr. Jian and Liu. What is your opinion? What is your opinion about the findings we have seen so far? What is your idea, your thoughts, on how to treat this? Jean?
Well, it's a challenging case. So congratulations to what you have done already, and that is solving what appeared to be the culprit lesion, which is RCA. Then you also opened the obtuse marginal branch, which I think was a very good idea to do it to the drug-coated balloon, given the size, the diameter of the branch. And now we have to focus on the LAD territory. And I think that the main decision will be whether or not to treat the left main. Now, the question is whether we can treat the LAD the way it is, and it's diffusely diseased, I think, which was shown on this OCT run without treating the left main. And I would be cautious there, because I think even though the ostium of the LAD does not look to have a severe critical stenosis, it is nevertheless burdened with plaque. So it may be difficult to treat the LAD without placing the stent into the plaque. And then we also saw that there was less than 5.0, I think it was 4.4, the minimal lumen area of the LAD, of the left main. And the additional problem there was also that, as far as I could see, there was also some soft plaque involved. So we basically have the situation where there is a critical stenosis in the proximal LAD involving a side branch. Then we have the situation that we have a diffuse disease, there was some calcifications, but on OCT, I did not see circumferential calcifications, which I think is important in decision-making process. So we have a tight lesion in the LAD, we have diffuse disease that extends into the left main, and then we have what appears to be also a significant stenosis of the left main with the soft plaque in a fairly young patient. If I saw it correctly, it's a 52-year patient. So I think given all these data, that a treatment should also focus on the left main. Now, to do a physiology interrogation in such a patient would be difficult because we have a critical stenosis in downstream, which is proximal mid-LAD. So to evaluate physiologically the left main stenosis, I think we would first need to treat the LAD stenosis in order to get that sort of a data, which could also be an option.
John, very great approach. Dr. Liu John, please.
Yes. I agree with Dr. Jian about the case. This is a diffuse lesion from left main to distal to the LAD. So from the angiogram, we can see very distal, there is still a very tight lesion. So maybe we can treat with a separate stem. Now from middle part, all the way back to left main, there's a very tight with calcified diffuse lesion. So I suggest to implant stent from mid LAD back to left main. So after the stenting should be very good post-dilate, because from the OCT imaging, we can find some calcified lesion. So because the calcified lesion not very tight with not more than 270 or 360 degree of the vessel. So I think we should not do any aggressive predilation with the calcified lesion. After the stenting, I think we just do the crossover circ. So we should not be treat the osteos of circ. The question is, we have many tight set branch in the LAD territory. So I'm afraid after long stenting, maybe some branch will decrease blood flow, maybe cause the ischemia. Thank you.
Thank you, Liu. It's absolutely, the approach is very interesting from both sides, because we are discussing a young patient with, here today, the calcium is not a big deal. It's mostly lipidic or fibrofatty plaques, but diffuse extension affecting proximality with the branches and the distal lead main. We have a question that we launched to the audience, and this is the outcome of this polling question, which is how you will treat lead main and LAD disease. And you see the vast majority of people, or the majority of people, is favoring the decision based on both imaging and physiology data, which is very encouraging. This means that people really relies on imaging, OCT, physiology data based on whatever, QFR, FFR. And this is the opinion of the most of the people. And regarding the treatment, we have several alternatives that were proposed to the audience. And as you can see, nobody is going for medical therapy, of course. Very few of them, only 20% surgery, but the most are driven again by the combination of angio, intracoronary imaging, and intracoronary physiology, 86% just to treat this case. I don't know if we have questions for chat, but regarding lead main, we have to remember that imaging is important. We, in our group in Spain, published 10 years ago the LITER study demonstrating that you can defer safely lesions in lead main when the minimal lumen area is over 6. But this does not imply that below 6 you have always ischemia. This is a very high negative predictive value threshold. Then between 5 and 6, maybe you need some physiologic assessment, and under 4.5 or 5, you can intervene. But between 5 and 6, I would say you need some physiological. Then it's a good answer by the people. We need to combine both imaging and physiology sometimes to make an idea. Here we have 4.4 by OCT, and nothing is clear that is significant. We have also the possibility with imaging to plan the strategy in lead main PCI, like when you can use these graphics, when you can decide if provisional or not. In this case, it looks like the way it's provisional because we don't have involvement of ostial circ. You can also plan the sizing of the stents, the landing size, whatever. And this is an example of IBUS. You can really select in LAD, like in this case, what's going to be the least landing site. You can select the pod diameter and also the length of the pod or the length of the stent. And with OCT, we can also check lead main. In this case today from Harbin, we could see that OCT is really rendering nice imaging for lead main without any blood contamination. Like in this case, when you have a bifurcation, LAD with all measurements with the lumen, the EEL, sometimes you can even measure the EL, the plaque distribution, the presence of lipid, calcium, etc. And now, what is your opinion about the assessment of lead main? Dr. Lim, for example, Dr. Yu, I would like to know your approach, your daily approach to these lesions, please.
Yeah, Jose, yeah, thank you. Yeah, my approach, daily approach is very much similar to the majority opinion here. Yeah, if it is very tight, then mainly based on the angio and the intracoronary imaging. For intermediate lesion, then we'll combine it with the physiology data. If there is a disease segment in only one vessel, then I usually opt to do the FFR assessment in the disease-free segment, knowing that the FFR true will be slightly lower compared to the FFR apparent. But if the FFR apparent is more than 0.85, then it is unlikely to be hemodynamically significant. So and in my practice, I tend to use a little bit more of the IVUS than the OCT, but both are excellent tools to provide us with a lot of information on the left main. Thank you.
Great. Thank you. Dr. Yu?
Yeah, sure. So my opinion, same as Dr. Lim. In my daily practice, mostly I use imaging guidance to assess left main, because not only to identify ischemia, but also if we need to treat this left main, we can get anatomy data from this left main. So mostly I use imaging guidance, but if only there was a lesion in intermediate lesion in left main and LD and both LD and circ was okay, probably I think physiology assessment should be better for this kind of situation. But most of the case, I think imaging is better.
Good. Excellent opinion. Dr. Haibo, we have any progress from the CAB lab just to give you the screen, or can we keep going with more discussion among the panelists?
Yeah, let's move to the CAS lab.
Okay, and during your just talk about 16. Talk about the strategy. I finished some work. I will talk about the work. Okay, from the beginning. I think that is very interesting. And first, because the third diagonal is subtotal occlusion. I just give a guide wire cyan blue and into with some difficulties, but not too much. And this guide wire into the side branch. And then you use 2.0 balloon and with 8 ATM to dilate it. But we notice that the distal part of the diagonal is not so good. And then we will saw the guide wire to make sure still have some stenosis along the distal diagonal. And then, but this side branch is not so big. And so I just used the scaling balloon 2.0 and to dilate proximal part. And with 1.5 balloon, next, 1.5 balloon, next. And to dilate the distal part of the diagonal. And after that, we give angio. Okay, And because this diagonal is not, I think that less than 2.0, it's just near 1.5. So I don't want to waste drug coating balloon for such small branch. And so I just keep it open. And then because from OCT, we know that the minimal lumen area site of LED is just fibrous without so much calcification. But the opening site of the second diagonal is not so good. And so we just put this guidewire into the second diagonal. After that, we measured OCT and to choose 2.75. 2.75 stent. The length is 33. And because the opening area of the second diagonal is not so good, and I choose a balloon protection technique for this patient. We use 2.0 balloon and protected in the set branch. And then with the 8 ATM to open a diagonal, and then 12 ATM to just dilate the stent. And this is the result after the balloon, after the stent implantation. And you know, you see that the second diagonal and the first diagonal is very good. And then because from OCT examination, we noticed that with some serious calcification. And then we use 2.75 balloon, the NC balloon, 20 ATM to post-dilate the stent to get a good enough area. And after that, you can see here is the OCT result.
Nice job with the branches, preserving the diagonals, stenting the proximal LED, and now showing with OCT. What is the result? We have here the standing LEDs and distal dissection, but you can comment, please.
Yes, and I think that is very interesting because the stent expansion is very good. The expansion ratio over 90% is 91%, and so very good expansion. And the proximal position is just exactly at the root of LED. And we have the distal dissection and the proximal dissection. You can see here is the distal dissection. A little into the medium, and just the arc is just near 90 degree, and the length is 2.3 millimeter, and the proximal dissection it's just a small one. It's just I think that this is very good. It's just intimal one, and so we needn't another stent for LED to left beam, but I think that we should talk about something about the distal dissection, and we should another stent or not. I want to get your comments.
Yeah, I think that you're right that the distal dissection looks more profound, more is a complete quadrant, longer. But maybe we have the panelists that someone in the group would like to make some comments.
So how about blood flow in LED? So it's good. Blood flow, TIMI3?
Yes, very good.
The blood flow, please. It's good. TIMI3.
The blood flow is very good. It's just normal. From the angle, you can't see the dissection.
It's really deep, is rich in the media. It's not more than 90 degrees.
From OCT, you can see the depth of dissection into the medium.
Into the medium.
Yeah.
Any comment from the panelists? What is your opinion? Who's going to? Hey, Dr. Guo, I think you have a comment.
Yeah, because this is a very focal dissection distally, but behind the dissection, we can see a very calcified plaque. And distal to this dissection, there's still some calcified lesions. So according to this distal part, I don't think this gonna develop as hematoma because of very diffuse calcified plaque. So I think maybe we can leave it alone.
What do you think, John? What do you think?
Yeah, I think it's interesting from two perspectives. The first is that if we look at the definitions or the proposals that we got from the EAPCI consensus document from the European Association of Percutaneous Corneal Interventions document, then this would probably satisfy the criteria for a significant dissection in terms of how long it extends. It's more than 2 millimeters, if I got it correctly, and in terms of the quadrants, and it goes into the media. However, there is a second point, which I think is also important, and that is to evaluate on OCT what would be our landing zone if we do proceed with the stenting of the distal segment. So it would be nice to see on OCT, if possible, if there is a landing zone with the second stent, if we decide for a second stent, that would land in a fairly healthy segment, so that we do not risk another distal dissection like this one.
Of course. And Takashi, Dr. Kim also have. Sorry, Dr. Sun Kim.
No. Yeah, it's very interesting case. I also agree with opinion Dejan, because this is a significant criteria for the major dissection to cover this distal stent. But another aspect, I think we should consider distal part of the LAD. If we put the stent, shorter stent to cover this region with landing to the distal healthy portion, I think this is we definitely I go for the another stent. But otherwise, I think we should keep this situation and continue some medical therapy with some heparization to prevent acute closure.
So I think they're doing a new acquisition from the CAP lab. Dr. Ho, are you doing? What's your next step?
And we just did two works. The first work is to measure the QFR after the first stent implantation. And the second, because from my opinion, and because the distal part of the stent for the dissection, we must pay attention to. And because if sometimes after and maybe hematoma, and because this IOD is very, very huge and it's very important to the patient, and this dissection into the medium, and the degree is 90, near 90, and the length is more than 2 millimeters. And so I decided to put another stent at the distal part, and you can see just angio. And we from the OCT examination, we choose the 2.5, 29. It's because the lesion of IOD is very diffuse, and from OCT we found just a near normal position for stent implantation. And so this is you can see I just from OCT and get where to exactly measure the length of the stent. And then this is 12 ATM, and with 2.75 post NC balloon to 16 ATM to dilate it. And here we just finished the final OCT for IOD. You can see the result.
Finally, stented the mid distal, the mid LAD to distal. They were able to found a reasonable distal landing site, as Jian was suggesting this as important point. And they found the place, and it's a longer stent, but it's true that it's going to the fibrotic place when there is no lipid accumulation or thin catheter trauma. That would be a problem, or large plaque burden. So excellent. Now there is no.
OCT result is good. And I think that good. Maybe the panelist chairman, can you guess the QFR result for this patient for left main?
Yeah, QFR, it's a great discussion. And I would like to know your opinion about this. But first, we have a poll by in the audience showing how they will do the left main imaging in this case, or assessment in this case, physiology of imaging, how to assess the left main. And you can see that 73%, the vast majority, opted for OCT. They decided to do OCT. 26 Haibos because it's a left main. We have half of the people, they say just imaging. And FFR in the other case, there are more a distribution of answers. Then my question is, what type of assessment? No, because QFR has been mentioned, it's very important. QFR, we know the result of the Haibo 3 in China, great trial, important trial demonstrating that QFR may improve outcomes in PCI. But Dr. Akasaka, what is your opinion about the use in diffuse disease of FFR, resting indices like RFR or IFR, QFR, and why?
Yeah, thank you very much. Yes, yeah, it is a very important question, and I really enjoyed the result of the LAD PCI by Professor Hall, right? She did a wonderful result in the LAD treatment, but yes, in our daily clinical practice, I prefer to do the resting indices evaluation in case with diffuse disease with focal tandem lesion, because we can identify which lesion may affect the ischemia, how much, right? Therefore, the resting indices give us very good information how to treat a lesion, and also after treatment, we can speculate the final result by the resting indices. I think in this case, anyone can agree, if we do the FFR, distal LAD should be very low, and the indication should be obvious, right? And the QFR, yes, except for the left main, we can speculate the good correlation between QFR and other physiological results, but I do not know the left main variation. There are good concordance or some discordance between QFR and other physiological evaluation. In this case, it is very important to decide the degree of the stenosis in left main. At that time, I think it might be better to measure the wire, put the CX, and then measure the FFR. If it is significant, we have to do the pullback and decide the region of the most significant portion. But if it is not so significant, we can leave it alone based on the physiology. However, in this case, this is a non-culprit lesion in non-STEMI, right? Therefore, some vulnerability have to take into account. And by OCT image, I can see some vulnerable portion in the left main. But it might be the discussion, I think. Still, there are lots of discussion about the non-flow limiting vulnerable plaque. There are some ongoing data, and some data shows only improvement of the prognosis is the limited. Therefore, I think physiological information is very important in this case. Yes.
In this case, good. Dr. Akasaka has raised very important issues for pertaining this case, and let me, Dr. Fei Won, let us know what is your approach to the assessment of this kind of cases.
Yes, Professor. Basically, I agree with Professor Takashi. And as we all know, despite the class 1A recognition and measurement FFR, however, in the real world use, the FFR is generally not so high. But recently, the clinical application of computational fluid dynamics or manufacturing assumption has enabled the combination of data between the coronary anatomy from imaging modality and the coronary physiology. And the QFR is one such modality, could provide a 3D quantitative coronary angiographic QCA-based FFR. This is also widely accepted in our center. And we also daily use this technique to determine the hemodynamics and lesion, because this technique could, without using the pressure wire or hyperemia induction. However, this also had some limited technique, because theoretically, QFR is more dependent on the anatomical stenosis severity than FFR, and it cannot fully reflect the individual variations, coronary physiology condition. However, RFR is the minimum value of the PVPA in the resting state of the heart without using the dilating drugs, including the systolic diastolic phase. LFR can simplify the complexity of the PCI, shortening the time and provide more convenience for the operator. Although the current RFR cannot completely replace FFR, it can be partially replaced, reducing the application of vasodilation. And we also sometimes use this physiology text to evaluate this development. But basically, this QFR, the accuracy between the QFR and the RFR is a little similar, but the QFR is a little bit lower than RFR. In this case, I think I basically agree with Dr. Takashi. We also need to evaluate the QFR or RFR from left second flag area. We also can finally conclude which part, which is, and then combine with the intracoronary OCT, the OCT measurement to finally determine the strategy. Professor.
Thank you very much. These clarifications are important. What is clear is that we need more and more combination of image and physiology to make really an idea what to do, how to perform the procedures. This is an example of after predilatation in this very long vessel in LED and showing how the virtual lumen is impacted. You cannot really make an idea of how to approach these very long lesions and how OCT is able to provide the lumen, but also estimate the EL, the vessel size in many points, and then to make the decision of what kind of balloons or tools you need to deal with very long diffuse lesion. We have now the example here of the new modality of software for OCT that is able to depict and delineate not only the lumen, but also segments of the EEL. With the segments of EEL, you can make an idea what is really the vessel size, and finally to plan what is the best landing sites or what are going to be the target for expansion of the stent size. This is really good. These are more examples of how finally the long lesion is looking after the stenting. And also we have even application that is a bit complex at a glance, but if you go step by step, you can see how to approach with OCT or how you can optimize procedures with OCT, not only relying on the lumen, but also in the EL, it is visible. And then you can size the stents according to the visualization of the EL, the different contour you can visualize. If you want to just to know more in detail this paper, you can just check it. And I don't know if in the CAD lab we have some advancement, if we have some new things done, or we could still keep going discussing, because I think it's important to know in imaging guidance for diffuse disease, the debate between lumen and EL plaque burden. And if no news from the CAD lab so far, we can discuss this. Dr. King, what can you tell us about?
I think it's compared to the IVUS, OCT there is some limitation to the penetration to the whole vessel sometimes. So I think if possible, we can visualize the EL, then we can do the measurement of the vessel size based on the EL. But sometimes it is impossible to visualize because of large plaque burden, then we can use a lumen. So in this situation, when we use a EL, we usually round down the below the point, and based on the we can use if we can use a lumen, we can use a recommended round up. So I think this is another important point. So also we can calculate the average diameter of the lumen or EL. We usually get a 2 orthogonal diameter that we can get an average diameter in this situation.
Dr. Xu?
Yes, thank you. So for me, I think if we use the OCT to guide the PCI, I think if we can measure the vessel size, I think plaque burden is very important because it can predict the future events after the patient is being followed up. Also, sometimes, as the Dr. Kim said, sometimes we cannot measure the vessel size by the OCT. So we can focus on the lumen size of the vessel. And also based on today's case, Dr. Ho put the second stent in the LAD, and the landing zone is in the fibrous plaque. So if we choose the landing zone for the stent implantation, I think the plaque characteristic is very important. To to put a stent in a fibrous plaque, maybe in the future the long-term result will be good compared with the plaque with lipid. So that's my opinion. Thank you.
Okay, do you think the software that I was showing in the previous slides is going to be helpful for making the selection of the stent sizing easier? Or Dr. Kim?
Oh yeah. Yeah,
it's about the software. Yeah. Yes.
Yeah. You mean the previous? You mentioned the previous. Yeah, some paper.
This is the software. Yeah, the software to identify the EEL in the OCT. The software I show in the video. Do you think it's helpful for the operators? So it's gonna be helpful in the cath lab.
Oh yeah, definitely. Yeah. I think it's
definitely.
Yeah, definitely. Yeah. Helpful to choose the optimal size of stent, but actually, I think if it's possible to identify the EL, we can use we recommend the EL at first, and then if it is impossible, then we can choose a lumen diameter.
Exactly. Good. Great. And we are going back to Harbin. Dr. Ho, what are you doing right now? We are really interested in the case, which is the main thing today.
Yes, I think like maybe because during your discussion, I think like two things are very important for this patient to put a stent into left main or not. The first is must from the imaging examination, and the OCT information is very important. And you can know like from OCT, the left main MLA is 4.6. And is a little much more than 4.5. And because from guideline, IROS guideline, and you know that between 4.5 and 6 millimeter square, and we should need physiology examination. But I think that another features about OCT is very important, because the OCT examination told us that in the left main, the lesions is just fibrous, very stable, and without lipid deposition. And so I think that for such area and very stable, we must based on physiology examinations. And during after the second stent implantation, before the second stent implantation, because we have some stenosis along the middle part of LAD, and the QFR for the distal part of LAD is 0.83. But after the second stent implantation, and the QFR value is 0.92. And I think that just between FFR, QFR, IFR, different physiology examination tools, but similar, and maybe for this patient, because 0.92 is enough for him to relieve the symptoms of ischemia. And so my decision is not to treat left main. And maybe we will give this patient very strict medication after PCI, such as PCSK9 inhibitor and something else. And so after 1 year follow-up, we will do QFR and maybe angio and OCT examination to make sure about the result. That's my decision.
Yes, Julio, let me know.
Chima and Dr. Hu, can we be back for a second to the left main in the first baseline assessment? First before stenting, the first one done.
Yes.
It is a very important, and also at this point, if you are going back and focus on the left main, okay,
Yes.
go
That's the
one
point.
by one. So number one, this is a fibrofatty, highly lipided, rich plaque. This is the osteum with, you can see very high intensity of the signals. And if we are going back to the first pullback, we can see more the component of the lipid, and we are below 4.4 in the first pass. The area, as adhesion was highlighted, was lesser than 4.5. So small lumen, younger guy, a very highly lipid-rich plaque at the level of the bifurcation. Well, personally, I'm much more in favor of finishing the job and the stenting. That is my personal opinion.
Yeah.
We would like to make some discussion about that.
Yes, I think they now this is making the case so interesting because we had the physiology assessment that was mentioned by Dr. Ho, but this 0.92 with this telling you that the narrowing of the lead main is not ischemic generating, or potentially it's not. But on the other hand, we had the anatomy, we had the morphology, and we see a large plaque, a lipidic plaque in a young patient. Then the value from the prognostic value or perspective, I think it's an important plaque that maybe could trigger an acute coronary syndrome that could be fatal in the location. Then please, panelists, help Dr. Ho and us to make a final decision about the lead main, because you have the physiology telling you stop, the imaging telling you take care because the lumen is 4.4, a lot of lipid. Please, some comments.
Yeah, can I have a comment, Dr.
Yes, sure.
Hernandez? Yes, yes. It is very important, the findings Julio pointed out. The left main, the minimum lumen area is less than 4.5, right? And also by OCT findings, it looks like a very vulnerable. Yes, fibrofatty with some macrophage or lipid content by the high signal, I think. Therefore, this region might be vulnerable, especially in case with non-ACS. There are lots of vulnerable region in the non-culprit site. Therefore, this might be vulnerable. But as I already pointed out, in prospective 2, there are no data showing the superiority of intervention if you put a stent at the site of non-flow limiting vulnerable portion. So at the moment, nobody knows the prognosis. Therefore, there are lots of discussion. In my daily clinical practice, I prefer to put a stent from left LAD to left main, because in this condition, we do not have any complication in the CX orifice because of the angle is very high, and we cannot have plaque and the carina dislocation, I think. Therefore, it might be very easy. But I do not know non-flow limiting vulnerable portion.
You are in pro with stent, but do you recognize there are some concerns? Dr. Frankie Tam, what is your opinion? What is your idea in this case? What would you do?
Well, first, I have to congratulate Dr. Ha for bringing this very nice case. I think one thing I would also like to raise is the approach to this case. This is a young guy, multiple lesions. We can see Dr. Ha do stenting and DCB. Nowadays, we know that for young people, we try to do the so-called the complete revascularization. I mean, to achieve a so-called residual syntax score, for example, less than 8. We have data that a low residual syntax score have a good prognosis. So in this young guy, Dr. Ha used multiple strategy to try to secure all the branches, even the side branches, the OM2, the diagonal 2, diagonal 3. And also she has a good balance of trying to avoid complex stenting. For example, she used gel balloon technique, she used DCB to try to avoid a complex tool stent. I think it's a great approach to these young people with significant plaque burden. And back to the question of this so-called vulnerable plaque but negative ischemia, I think it's a tough call because there's no data. We know that this plaque is vulnerable, but somehow we know data from CT scan is that although this plaque is vulnerable, somehow this vulnerable plaque can be stabilized with medical treatment. So it's really hard to say. But in this case, if this is my patient, I would probably put a stent because there's a small dissection in the proximal stent edge, and there's a small lumen, and there's a vulnerable plaque. In this case, I will put a stent. But again, even if we don't put a stent in here, I think it's still okay. So it's a very controversial issue.
Good, thank you. And Dr. Tse-min, you please, your opinion, and we finish the round.
Yes, I think this is a wonderful case for demonstrate this kind of I think equivocal Lehmen lesion. But I think from the OCT, you can see that the Lehmen lesion is a little bit short, but it's a fatty lipid plaque. Before the LED stenting, personally, I would put a stent extend from the Lehmen distal to the LED. But because after we put the stent only at LED and causing a small dissection at the proximal end, although that the FFR is more than 0.92, I think personally, in my opinion, I would put the stent at the man, especially the young guy, and especially there is a dissection over the proximal stent. But I think I agree with the Dr. Tan. This is a controversial here.
Do you have the hand raised?
Yeah, thank you very much. It's of course a controversial issue because we do not have a definitive randomized data to answer it. So in that situation, we have to recur to observational data that we have in such situations. And I think there are two important pieces of information that we do have. The first one is if you look at the FAME trial, for example, at 5 years, in the subset of patients with the FFR above 0.80, there was an 8% incidence rate of MI over the follow-up, 4 to 5 years. So by not stenting the lesions that are with the FFR above 0.80, we have at least the incidence rate of, let us say, 2% per year of MI. Now, having an MI in this patient, it is clearly, given the location, what kind of a risk that would pose. I think this is one of the pieces of the data that we should not neglect. The second piece of the data, which I think is important, or the second side, is the fact that we actually, by proceeding with the intervention, we finished our stent in the plaque. We know from previous IVUS studies, but also on this OCT pullback, that there is a diffuse disease extending from the left main into the LAD. It is a continuous plaque mostly, and we know that from previous imaging studies as well. So given that, and we said this yesterday as well from the ultimate trial, knowing that having a plaque burden on stent edges is a risk for future stent-related events, this is something which we need to take into account, I think, in this case as well. So given that no definite randomized data are there, I think that, of course, we can do both ways, but it would be my feeling also that to leave this sort of a lesion in a young patient of 52 years may be a risk that would not be acceptable to all doctors. Thank you.
Thank you. Dr. Ho, what is the final decision making after all this round?
Yes, I think that all the panelists maybe want to stent implantation, but I really have different ideas. And from the beginning, and you know, that this patient is multi-vessel disease, I think that maybe the position for ischemia is RCA and the proximal IAD. And these two parts, we must put stent implantation. Just because this patient is very young, and so I don't want to too much mental implantation for this patient. So I just use imaging guided and physiology guided for this patient. And for imaging, OCT is very important to make sure about the stability of left main. And so this is fibrous fatty with some kind of macrophage infiltration, but the fibrous cap thickness is just stable. And so just with starting and PCSK9 inhibitor and with many patients after 6 months or 1 year follow-up, we found that the lumen area enlarged and the plaque become more stable. And so I think that for this patient, I original idea for this patient to the first is to relieve ischemia, and the second is the safety of the patient. And so I use OCT to decide the stent from IOED proximal, but with dissection to the middle part of the IOED. And OCT examination makes sure about the good result for stent expansion. And so this is enough for the relief of his ischemia. And so I think that QFR result and OCT result together and make me make the decision not to plant stent into left main. I think that maybe from my scale and a stent into left main is only 2 minutes. That's okay. I will just finish this PCI. Very beautiful. But I think that maybe for this case, like next year, we will invite the patient back to our cath lab and to make sure about the angio and the QFR, maybe FFR result for this patient. I think that maybe we need some time.
Totally understandable. There are many circumstances in medicine where you have a rationale supporting both strategies that appear to be so conflicting or on opposite, but they are not so much. And it's because, as you said very nicely, sometimes we put the stents because we fear some scary feelings, no? But from the point of view of science and evidences, of course, the weight between both, the balance between both decisions is 50-50. And in this case, it's also a case for relying on therapy, no? And PCSK9 inhibitors, high dose statins, follow-up imaging, and then the patient maybe is doing well without more metallic footprints in the coronary tree. On the other hand, you prefer to implant the stent because you feel better, because the result, as Dr. Ho says, is more beautiful. The angiography looks better. But I don't know, on one hand, you may have an acute coronary syndrome in this plaque, but also you could have a restenosis in the distal stent or thrombosis. Then it's difficult. It's really, it's not complex. It's very complex sometimes to make decisions in these circumstances. I don't know, meanwhile, you have any comments? Just to show you some slides dealing with how we optimize imaging with Haibos, which this is our graphics from our paper in your intervention, yes. And Julio, just tell me, what is finally your, what?
Well,
yes.
I think that if you can go back to the cath lab, is so important, this discussion. So forget the slides that we had.
Yes,
everybody is concentrated on the story of the left main, and perhaps if we can show again the images of left main. I wanted to make a couple of comments. So I wanted to have a full screen, the cath lab with this imaging of left main. Perhaps if you can ask Haibo to bring the image of the cath lab full screen with the OCT. Might we have it, Haibo?
Can we go? And can we see in the biggest screen?
Sure.
And to spend a couple of more minutes on this aspect of the left main and the lesion, the original lesion. Not this one, but the first. For all this one, this is an additional pass, but we wanted to see the bifurcation.
After this.
If you, okay, also
this is
before.
after the first stent implantation.
Okay, this is the baseline.
Okay, leave this one. So couple of points. Number one, as you might see, there is a lot of plaque burden on the opposite side of a flow divider. That is the usual position in the left main. So I cannot expect that the plaque will regress opposite of flow divider. despite the fact that you are using potent PSK9 inhibitors, you might eventually stabilize, but very difficult, no proof to regress. So this type of turbulence of the flow is going to stay. The second is we are measuring any value of the hemodynamic now in this condition. Suppose is China, suppose is a summer, suppose you have 44 degrees, suppose is humid. I'm not sure that the lumen is going to stay the same. The measurements we have today is the measurements at this point without taking into account many different factors. So I wanted to place on the table, because this decision is so sensitive and difficult to be done, but you needed to have the full landscape in front.
I think that, of course, my point of view, I am one of the main author of the LITER study, and with a lumen like this, we implanted stents because we were proposing 6 or between 5 and 6 on physiology assessment. In this case, is below 5. That in Spain, at least, this will be extended. But to be a devil's advocate, I will say that in all the studies assessing FFR in lead main without imaging, the prognosis of those cases with a negative FFR values was good. It's true that in these circumstances, maybe the FFR is not reliable because we did just a PCI now, but also there is evidence for the resting indexes, like in the defined lead main, that IFR is able to defer lead main lesions safely without imaging. The problem is here that we have both. We have imaging and physiology, and both are telling us different things. We have a conflict between physiology, QFR, FFR, telling that it's not significant. We have, on the other hand, imaging showing a borderline, or I would say a small lumen, because for me, less than 5 is a small lumen, not borderline, and a plaque that is, from a histologic point of view, is lipidic. It's not a thin capsuloatheroma, but it's a fibrotic sun component lipid in the bottom part of the imaging. But to be honest, it's a conflicting because we have both sources of information. Sometimes when you have a lot of information, you have more problems to make a decision because you have different, sources of decision. What is your other people in the panel providing new insights, new proposals? I think all of us make our own statements.
So because I'm
yes.
sorry, I'm just interested in that. Does anyone agree to test a real FFR for this left-hand case?
During your discussion, I prepared to do FFR, but Professor Jia said that QFR must be suitable for this patient. I think that's different idea, but I think that QFR value 0.92 is very high enough. If the QFR is just 82, 81, I will make sure about the real FFR. But 92, I think that maybe is enough information to let us and to just, I think that for this patient is very a teaching case to combination from imaging and physiology. And maybe I think that we now have the controversial idea for such kind is stent implantation or medication. But after some RCT studies, I think that maybe we can make sure about on now the strict medication in this time. Maybe I think that no stent implantation for left me is my choice.
I think that in the setting of a very long stent in LAD and diffuse disease, I think the macrovasculature in the LAD is not going to give a very high parameter response. And my fear is that FFR is going to underestimate maybe the severity of the lesion, the significance of the lesion in the lead main, because it's not going to be, adenosine is not going to be able to recruit the macrocirculation in this case when we have possibility of multiple micro embolization of debris and particles after a very long stent in LED. And then resting indices could play a role, but the evidence with them is less in lead main. It's much less compared to FFR. And regarding QFR has pitfalls, and particularly in the lead main setting. Then, but you are right, the value is high. Then we had here, as I say, the conflict and the confrontation of two different positions. And finally, the last word is in Harbin. They are going to make the final decision, but we can help them to provide more arguments and more rationale. Anything else from the panel? Because this is a hot, really, we didn't expect to have this very important discussion in this case, but this making the case great, and the session really fantastic.
Jian want to say something.
Jian.
Yeah, I just wanted to add, but I think that you just mentioned it, the coronary microcirculation, to complicate things further. And I think this is the beauty of the discussion. This is the real life. So we have somewhat conflicting intravascular imaging and physiology. And in order to explain the physiology, I think what you just said is very important to understand the coronary microcirculation. So getting for example, the FFR wire out, which has the capability of measuring the IMR, thermodilution IMR, could tell us something about the microcirculation and whether we can trust the FFR value. But this is then the third aspect of the story. So we have epicardial conductance, which we assessed with the QFR. Then we have intravascular imaging, which we did with the OCT, and the characteristics of the plaque together with the area, which was small. And then the third aspect would be coronary microcirculation. So we would need to base our decision on all of these three aspects without having randomized data for any of that. So I think this is the fact that we need to acknowledge. So this discussion is important, and I think that all of the opinions were very good. And I want to congratulate, of course, people in the cath lab, because it's not easy to be in the cath lab. So congratulations for staying with us for this discussion.
Absolutely.
So, Jose, let's say the few words. Number one, the operator is Dr. Hu. He did a phenomenal case. He has the responsibility on the patient. I think that the case of today went completely in a different direction. We were expecting to have some discussion about the left main, but not so hot in terms of discussion as we had. So I think that in the interest of time, this was a great experience. I think it should be nice to have this case also reply around to see. We are going, we are giving the ball back to Dr. Hu for the final words on this case, and then we will go to possibly to finish the transmission. So Dr. Hu.
Okay, thank you so much for your discussion. And for this young guys, and we know that it's multivessel disease. And from last week, and we finished the RCA PCI. And for from the left main, left coronary artery, and we noticed that so many positions we must to do something. And the left main to do stent or not. And for the third OM is subtotal occlusion, and the third diagonal is subtotal occlusion. And I think that maybe left coronary artery, the ischemia part is just proximal LAD, is very tight stenosis. And so I think that the most important things for this patient is to make sure about the opening site of ILAD is good or not. If it is good, we can just put stent very precisely at the beginning site of the ILAD. And the second important thing is to protect the second diagonal. And so I just in minutes to open the OM and the third diagonal to get the good blood flow. And then from the OCT examinations, we found like the opening site of ILAD is just okay. And so, but the second diagonal is just not very good. And so we use the balloon protection technique, and from the beginning site of the IOAD and from the OCT measurement along stent, along the proximal to the middle part of the IOAD. Outlight, I think that OCT is very important to make sure about the result of stent, because from the MILD max, and so we know the rules, and OCT found distal dissection. This is longer dissection, longer than 2 millimeter, and degree is 90 degree, and so into the medium, and so we decide another stent at the distal part. And outlight, we are just the mainly question is to put stent along LAD to left main or not. And because from OCT examinations, I think that the result of left main is near 4.6 square millimeter, and so it's just between 4.5 and the 6 square millimeter. And so we decide to do QFR measurement for this patient, and it's very interesting. Before the second stent implantation, and the QFR is 0.83, but after the second stent, and the QFR value increased to 0.92. And this value make me to believe that the ischemia is mainly from the IOAD, and maybe not get so great relation with the left main. So from this case, I think that we from know something so much more information from imaging examinations and physiology. But now we have some controversial idea. But I think that's not important, because different patients maybe have different methods to treat. But after, if all the cases, and we have precise and very good result after the guidance of imaging and physiology, I think that this is good things for all the patients. That's all. Thank you.
Okay, Dr. Hu and Dr. Hu, may we ask to have a last final shot on right oblique projection of the left main and the circulation, how it looks like? Please
okay.
Do an angle, final angle.
Yes, we have 2 final angle. You can see the result. 没有到4. This is the final angle.
Okay, because ball back to you for decide if we needed to finish the original plan, or otherwise we think that this case was enough informative. And thank you, everybody. Back to you, because thank you very much, Dr. Hu. Fantastic work.
Yeah, fantastic work, really. Dr. Hu was able to tackle with diffuse disease, small vessel disease, bifurcations, optimization of the stenting, combined imaging and physiology, and finally a decision making regarding the distal and main. That is geographically ambiguous, was requiring physiology and imaging. Finally, the decision is well argumented, well rational. But on the other hand, we have some people that was pushing for the stenting, like me and other panelists. But Dr. Hu, in a very solid argumentation, she believes that the patient can go without stenting now, but to go with medical intensive therapy for lipid reduction and so. And okay, this is not the expected. We were expecting a stenting in the main, but this is real life, as the Jian said. And sometimes the initial strategies change according to how things are going on. But I respect a lot, highly respect for the decision, absolutely. They think there were reasons for both strategies. And then, Julio, I don't have more comments because this is a result, it's a good result. And the point of the main allows to make, to have a great discussion. with outstanding faculty and their opinions, and we could just end up the transmission of the case because it was really great.
So thank you very much, Jose, Dr. Hu. We would like to thank you and to thank all the Cath Lab team. It was a very challenging situation, but you made our life much more challenging compared to what we are thinking usually, because now we have another things that is back to be discussed. So if you don't mind, I wanted to go back to Haibo Jian and to close with a very big thanks to all the faculties this meeting. Haibo, can you take the ball and say the few last words with after these 2 days of full meetings, please?
Okay, thank you. So, on behalf of Professor Yi, I would like to thank you all the excellent panelists, and we have completed 2 sessions in 2 days, very compressed 2 hours with 2 beautiful live cases, which was done by Dr. Ho. And thank you so much for your continued support. We did last year in June and this year in this very challenging time. We have a very wonderful live case transmission. I think all of us, including our panelists and audience online, learned so much and very informative and educative session. And this session will be on demand online, and we will all audience can review our session at any time, even after close our session. So thank you so much for joining us, Dr. Ji.
Okay, thank you everybody. Don't forget that today we had a transmission going across the globe. Really, we are working together from China to Japan, to Korea, to Hong Kong, to Taipei, to Singapore, and then back to Europe. So thank you very much for the time and the energy you spend with us. Special thanks to Jose for this very nice lead conduction of the meeting. And see you possibly soon in person. And anyway, see you next time to another Harbin imaging and physiology meeting. Thank you very much. Take care.
Thank you.
Bye.
Thank you.
Bye-bye.
Bye.
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 Bye-bye.
Bye-bye.
Thanks, Dr. Liu.
Thank you. Bye-bye.